Okay, the topic of today's class is retinal anatomy and symptomatology, and it will be moderated by Dr. CCN ma'am. Eyeball has three coats. Outermost is the fibrous, which includes the cornea and the sclera. Middle is the vascular, including iris, ciliary body, and choroid. And innermost is the nervous, which includes the retina. Retina is one of the most developed structures. Embryology of retina. It begins as neural tube, which divides into forebrain, midbrain, and hindbrain. The forebrain, prosencephalon, later on divides into telencephalon and diencephalon. On day 25, the diencephalon protrudes to form the optic vesicle. The optic vesicle further elongates to form the optic stalk, and then later invaginates to form the optic curve. The optic curve forms the outer, thinner part, which is called as the retinal pigment epithelium. Inner, thicker part, which is called the neurosensory retina.
One significance of this, this embryology, the outer thinner part forms the RPE and the inner thicker part forms the neurosensory retina. So what is retinal detachment? Yeah, that's the main thing here. That's why the retinal detachment happens, because of the separation between the RPE and the neurosensory retina. This embryology has a reason. So this is one of the reasons why retinal detachment. The embryology of both the layers is different. Okay.
The space between both the layers is called as subretinal space. The inner layer later on divides to form three cells: matrix cells, the mantle cell layer, and the marginal layer. Matrix cells divide to form the rods and cones. Mantle layer give rise to the bipolar cells and the ganglion cells. The marginal layer, in combination with the ganglion cell layer, forms the nerve fiber layer, which forms the optic stalk and the optic nerve. Now the vitreous is formed partly from the ectoderm and the mesoderm. Over here we can see a vertical section from the wall of diencephalon, which shows the optic stalk and the optic curve. In the middle of the stalk and the curve is the choroidal fissure, which usually closes by 6th week of gestation. Failure of its closure is known as RC colopoma. Now these are some anomalies of development. At the age of 3 to 4 weeks, the stage of development is the optic pit and the vesicle. And anomaly failure to form is used to anophthalmia. By 5.5 to 6 weeks, there is a closure of choroidal fissure, and failure can lead to coloboma. By 8 to 30 weeks, neuroretinal histogenesis occurs, and failure to form can lead to Leber's congenital amaurosis. Moving on to gross retinal anatomy. Extent of retina is from the optic nerve to the ora serrata anteriorly. Boundaries: externally it is surrounded by Bruch's membrane of choroid. Internally it is surrounded by the vitreous. Thickness of retina is very variable, but the thinnest part is the fovea, which is only 0.1 millimeters, and the thickest part is the disc. Moving on to the regions of retina, it can be mainly divided into three regions: the optic disc, the macular lutea, and the peripheral retina. Optic disc, it is a pale pink structure about 1.5 mm in diameter. It is pale due to absence of any vascular choroid behind it. It is 3 cm nasal to the center of macula. It is the area of termination of all retinal layers except the nerve fiber piercing through the lamina cribrosa, which run into the optic nerve. Optic disc can be further divided into two parts: the optic cup and the neuroretinal rim. Now the applied anatomy is disc pallor and thinning of NNR raises the suspicion of glaucoma. Okay, now the differences between normal optic disc and a glaucomatous disc. Glaucomatous disc will appear pale and with a thinning of NNR, whereas normal optic disc is slightly pink and orange in color with a healthy NNR. The area centralis or the posterior bord, it is 5 to 6 mm in diameter. It is the area between the superior and inferior temporal arteries, and it contains macular lutea. Macular lutea can be further divided into the innermost part or the central pit, fovea, avascular zone, parafoveal zone, and perifoveal zone. Macular lutea, its circumference is 5.5 millimeters. It is 2 disc diameter away from the optic disc. It represents central 15 degree of visual field. It is yellow in color due to presence of xanthophilic carotenoid pigments zeaxanthin and lutein in the ganglion and its ganglion and bipolar cells. These pigments have antioxidant properties to prevent photic damage. Fovea centralis, it is same diameter as disc, 1.5 mm. It represents 5 degree of visual field. Thickness is 0.25 mm. Clivus is the area of downward sloping between the border of margin of fovea to the margin of fovea. It will be represented in the further slides. Foveal avascular zone is the area between the fovea and the fovea. It is one of the avascular areas in the retina. Fovea is centrally thin indentation at the fovea. Diameter is 0.35 mm. It represents 1 degree of visual field. Thickness is 0.13 mm. It has highest cone density and therefore highest visual acuity. Umbo is tiny depression at the center of fovea and is responsible for the foveal reflex. Can any of the second year define what is meant by foveal reflex being dull and bright? Moving on to the peripheral retina, could be due to fluid collection. It can be divided into near periphery, mid periphery, far and extreme periphery. Near periphery is the area of 1.5 mm surrounding the macula. Mid periphery is 3 mm. Its outer limit is also known as the equator. Far periphery is from equator to ora serrata. It is variable width depending on the ocular size and refractive area of the patient. Extreme periphery is also called as the ora serrata. Now equator, it is clinical equation can be drawn from the imaginary circle drawn through the ampulla of vortex veins. Every eye has 5 to 6 vortex vein. The ampulla of the vortex vein, we can draw an imaginary circle from which we can get the equator. Now this is a fundus diagram. It is very important for exam point of view. The innermost layer is the equator, outer is the ora serrata, and pars plana is the outermost. It can be asked in exams. Ora serrata. Serrata means tooth-like. It is end of retina and beginning of ciliary body, mainly the pars plana. It is second thinnest layer after fovea. Serrations are more nasally than temporally. Distance from optic disc is temporally it is 24 mm and nasally it is 18 mm. Retina layer is firmly adherent to both vitreous and RP, and thus it has rare occurrence of RD at the ora. And detachment beyond this point is known as pars plana detachment. It is a waterside area between anterior and posterior vascular system, and only one blood vessel is present, which is the explanation for most common place for peripheral retinal degeneration. Now the transition of retina into non-pigmented epithelium at the ora. Over here you can see the ora becomes the non-pigmented epithelium of ciliary body. The RPE continues as the pigmented epithelium of ciliary body, and the Brooks external limited membrane of retina continues as the Brooks membrane of choroid. So retina is mainly made up of 4 types of cell, and their synapses arranged in 10 layers. From inner to outermost is the inner limiting, internal limiting membrane, then the nerve fiber layer, ganglion cell layer, inner plexiform layer, inner nuclear layer, outer plexiform layer, outer nuclear layer, external limiting membrane, photoreceptor layer, and retinal pigment epithelium. These in red are the cells present. Ganglion cell layer, bipolar cells, photoreceptor, and retinal pigment epithelial cells are main cells. Now the order of transmission. Retina has 3 subneural pathway. Photoreceptors are the sensory receptors and the first order neuron. Bipolar cells are the second order neuron, and ganglion cells are the third order neuron. This is according to Ryan's. In A.K. Khurana it is mentioned differently. Bipolar cells are the first order neuron in Khurana. Axons of all ganglion cell layers form the optic nerve at the end. Retinal pigment epithelial cells. These are single layer hexagonal cells. This is situated between the Brooks membrane and the neurosensory retina. Apical surface has the microvilli to hold the rods and cones. Apical surface also contains the zona occludens, which forms the tight junctions and form the outer blood retinal barrier. The adjacent cells are connected to each other by zona adherens, but it is not a part of outer blood retinal barrier. Now the mechanism of serous retinal detachment. The RP is firmly adherent to Brooks membrane and loosely attached to neurosensory retina. Space between is called the subretinal space. Separation of RP from neurosensory retina is called the retinal detachment, and fluid in between is called subretinal fluid. A normally functioning RP, if there is focal point of leakage, the cells can work and force the leak out of. If the RP is compromised, then the leak can expand because the RP cells are not functioning. Retinal pigment epithelium has 2 pigments, melanin and lipofuscin. Melanin is situated at the apex in the cytoplasmic granules called melanosomes. Function is absorption of damaging wavelengths of light. It is brown in color, unequal representation in each cell, which leads to granular appearance of the fundus. Lipofuction is accumulates with age, derived from aged and damaged outer segment lipids, ingested and digested by the RPE cells. Now, functions of RPE: photoreceptor renewal, integrity of subretinal space by outer retinal barrier, phagocytosis of old photoreceptors, regeneration of visual pigments, regeneration and repair. Now, moving on to the photoreceptor layer. Rods, it has two cells, rods and cones. Rods are has scotopic vision due to the pigment called rhodopsin. Rhodopsin has a function of sensing contrast and motion. Least number of rods are present at the fovea. Number increases towards the periphery. An estimated number is 110 to 125 millions. Cones are responsible for photopic vision. Visual pigment is iodopsin. It is responsible for fine resolution, spatial resolution, and color sensitivity. Highest is at the fovea and it decreases towards the periphery. Estimated number is 6.3 to 6.8 million. Now, structure of photoreceptors, rods and cones. The outer segment contains the lamellar disc, which contains the visual pigment stacked on top of each other. This disc is periodically phagocytosed by the RPE cells, which are responsible for their renewal also. The inner segment contains the myoid and ellipsoid. Myoid contains the mitochondria, which maintain the cellular homeostasis. Ellipsoid contain Golgi body and other organelles. Cilium is the connecting stalk between the inner segment and the outer fiber. Outer fiber extends from the inner segment to the cell body. Cell body contains the nucleus, and inner fiber has synaptic terminals with the bipolar cell. Inner fiber, the synaptic terminal of rods are called as spherules and cones are called as pedicles. Bipolar cells, they lie in the inner nuclear layer. Dendrites of these cells synapse with photoreceptor and axons with ganglion and amacrine cells. There are three important subtypes. Rod bipolar cell connecting several rods to one or more ganglion cells. Midget bipolar cells, many cones to many ganglion cells. Flat bipolar cells, single cone to single ganglion cells. Ganglion cells, dendrites of ganglion cells synapse with axons of bipolar cells and amacrine cells. Each cell has single non-myelinated fiber which form the nerve fiber layer on the innermost surface. Axons of ganglion cells make 90-degree turn to reach the inner surface of retina and become the optic nerve. Now moving on to accessory cells of retina. Horizontal cells form the outer plexiform layer, synapse with photoreceptor, bipolar cells and other horizontal cells. The amacrine cells are present in inner plexiform layer, synapse with ganglion cells, bipolar cells and other amacrine cells. Mueller cells are principal supporting glial cells of retina, provide structural support and nutrition to neurosensory retina, extend from vitreous to the inner segment of photoreceptors. Other supporting glial cells of retina are astrocytes, oligodendrocytes and microglia. Moving on to layers of retina. External limiting membrane. It is not a true basement membrane, as time junctions or zona adherence between cells of photoreceptors and Mueller cells. Function is selective barrier for passage of nutrients. Outer nuclear layer is formed by nuclei of rods and cones, maximum at fovea, more number of cone nuclei and thinner at periphery. Outer plexiform layer, synapse between rod spherules and cone pedicle with dendrites of bipolar cells and horizontal cells. Inner nuclear layer, nuclei of horizontal cells, amacrine cells and bipolar cells are present here. Inner plexiform layer, synapse between bipolar, amacrine and ganglion cells are present here. It is absent in fovula. Ganglion cell layer has the cell body and nuclei of ganglion cells. It is absent in fovula. Nerve fiber layer contains unmyelinated axons of ganglion cells converge to form the optic nerve head. And lastly, it is the inner limiting membrane, which is the innermost layer. It is a basement membrane formed by extension of Mueller cells. Now, how the formation of layer occur? The outermost is the RPE, then the cone and the rod cells. Outer segment constitutes the photoreceptor cells. Then it is the external limiting membrane, which is not a true basement membrane. Then it is the outer nuclear layer formed by the nuclei of cones and rods. Then the outer plexiform layer formed by the synapse between the photoreceptor and the bipolar cells. And then the inner nuclear layer containing the nuclei of horizontal cells, amacrine cells and bipolar cells. Then the inner plexiform layer formed by the synapse of bipolar cells and ganglion cells, and then the nerve fiber layer, ganglion cell layer, nerve fiber layer, and internal limiting membrane. Now structures at the fovea. Fovea is a rod-free region with abundant cones. Foveola is rod-free region in macula covered only by the internal limiting membrane. All the other membranes are absent here. So basically, fovea has abundant cones, and all the nerve fiber layers are going obliquely into the fovea region and not up into the fovea. The synapse here, not in the middle. This is called as the Henle's layer. Moving on to the blood supply of retina. Outer 4 layers are supplied by choriocapillaries. Inner 6 layers are supplied by central retinal artery. Outer plexiform layer has a dual blood supply. Fovea is an avascular area which is mainly supplied by the choriocapillaries. Macula, superior and inferior temporal branches of central retinal artery. Sometimes the cilio-retinal artery also supplies, but when it is present, it helps retain vision in CRO. Retinal arteries are also end arteries and do not form anastomosis, so their occlusion invariably leads to ischemia. Usually, retinal vessels do not cross the midline, and collaterals crossing the midline indicates vaso-occlusive disease.
The ciliary artery may not always supply the fovea, okay? So it may supply only a part of the papillomacula bundle. It may supply a large area of the macula also. So a lot of variations in the ciliary artery. So just because the ciliary artery is there, it's not that the fovea will be spared, okay? It can still have a fovea involvement despite having a ciliary artery, okay? So why is it not involved in a central retinal artery occlusion? Where does the ciliary artery arise from? It is a branch of the short ciliary vessels only. Short ciliary arteries, they perforate around the disc, right? One of them comes into the. So it's separate from the central retinal artery. So the central retinal artery occlusion, this will be spared actually. And also in FFA, the ciliary retinal artery fills much earlier than the central retinal artery. Okay, you can see it in the choroidal phase.
Arrangement of retinal capillaries. Retinal capillaries are arranged in 3 layers: superficial vascular layer, intermediate vascular plexus, and deep vascular plexus. Superficial capillary plexus is present between the nerve fiber layer or the ganglion cell layer. Intermediate and deep capillary plexus is present between the ganglion cell layer and the inner nuclear layer. Deep is present between inner nuclear and the outer plexiform layer. Deep layer is also more dense and complex. In fovea, all 3 plexuses merge to combine and form a single ring. Now the inner blood retinal barrier is formed by tight junction.
What is more important is this is a end vessel actually. So the deep vascular plexus arises from the intermediate and the superficial vascular plexus. So they are kind of end arteries, okay? So they don't have flow from anywhere else. So if the superficial vascular plexus is blocked, even the intermediate and the deep are affected actually. Okay? Can you tell me a condition where the superficial vascular plexus is affected? Clinically, what do you see it as? We're not talking about central retinal artery occlusion. We're just talking about the vascular plexus affected, it's ischemic. So what will it cause? It will cause inner retinal ischemia because that supplies only the inner retina, right? So what do you see that clinically as? Cortinal spots. Okay.
Inner blood retinal barrier is formed by tight junctions between the endothelial cell, Mueller cells, and pericytes. Endothelial cell and pericytes are present in a ratio of 1:1. In diabetes mellitus, there is decrease in pericytes, and in aging, there is decrease in endothelial cells. It is vascular, unlike outer blood retinal barrier, which is epithelial. Now, retinopathy of prematurity or retroradial fibroplasia is due to failure of development of retinal blood vessels by vasoconstriction, which leads to reciprocal vasoproliferation of blood vessel due to leaky endothelial tight junctions. Moving on to anatomy of vitreous. Vitreous is inner, transparent, jelly, colorless, and hydrophobic gel-like substance. It is largest cavity in the eye, forming 2/3 of the volume of entire globe. Weight is 4 grams and volume is 4 cc. Function of vitreous is optical function. It has a refractive index of 1.33. It has a supportive function. It forms a tamponade so that the neurosensory retina is forced against the RP. Boundaries of vitreous are anteriorly it is formed by ciliary body and posterior surface of the lens, and posteriorly it has the neurosensory retina. Composition of vitreous is 99% it is water and rest is structural protein, namely hyaluronic acid, chondroitin sulfate, VIT1 and fibrillins. Vitreous gel is reticular meshwork of type 2 collagen, which is the major component, interspersed with structural proteins which provide viscosity, elasticity and tensile strength. Viscosity of the vitreous is due to sodium hyaluronate. Parts of vitreous: hyaloid layer or the membrane. It is the outermost surface of the vitreous. It is not a true membrane. It has two layers, the anterior and the posterior. Cortical vitreous, it is the entire peripheral vitreous which forms only 2% of entire vitreous volume. Highest density of type 2 collagen and structural proteins. It contains hyalucytes or vitreous cells, which are the metabolic centers of vitreous, synthesize hyaluronic acid and acts as phagocytes. Third part is the medullary vitreous. It forms the majority of vitreous. It is similar to cortical except less fibrillary components and cells. Now the anterior hyaloid membrane. It is 1.5 mm anterior to the ora, lies in contact with the pars plana, ciliary processes, ciliary zonules and posterior lens capsule. It has Weger's ligament, which is attachment of anterior hyaloid membrane to the lens capsule in a 9 mm ring. Space posterior stays within that ligament is called as the Burgess space or the retrolental space. Now the Clockett's canal or the lateral canal is central canal running from the posterior lens capsule to the optic disc. It is remnant of hyaloid artery. It is S-shaped. Posterior hyaloid membrane or the posterior limiting membrane extends from the vitreous base to the optic disc. It forms the vitreoretinal interface, which is connection between the internal limiting membrane of an neurosensory retina to the posterior hyaloid membrane. It is facilitated, this vitreoretinal interface is facilitated by fibronectin and laminin present on the outer surface of posterior hyaloid membrane. It forms dense adhesions between both. Attachments of vitreous is at 5 places: ora serrata, optic disc, back of the lens via Weger's ligament, fovea and along the retinal vessel. Strongest attachment is at the vitreous base. It is the region straddling the ora serrata. Now the areas encircling the ora serrata by 2 mm anteriorly and 4 mm posteriorly to the pars plana is the vitreous base, this area. Posterior vitreous detachment is separation between the posterior vitreous on the posterior hyaloid membrane and the neurosensory retina, with the vitreous collapsing anterior towards base, which is the strongest attachment. Now PVD affects most eyes by 8 decade, but usually the onset is by 6th decade. There is no gender preponderance. It occurs earlier in myopes and eyes infected by inflammation, including status post trauma, and when there is a surgical vitreous loss. Pathophysiology of PVD is firstly by liquefaction or synchiasis, and then later by syneresis, which is collapse of central vitreous. It leads to rupture between the posterior hyaloid, which pulls the vitreous, and the liquefied vitreous flows into the retrovitreal space, separating the posterior hyaloid from the retina. PVD continued. It is typically starts as partial separation in the perifoveal region and is asymptomatic until it progresses to the optic disc. But when the separation of peripapillary attachment from the optic nerve head occurs, it forms a partial or complete annulin known as Vogt's ring or the Weiss ring. Flashes and photopsia are pinpricks or spots of light seen in the field of vision. These are entopic phenomena, which means visual effects and sensation that occur from causes within the eye itself. Phosphenes is a type of entopic phenomena where the perception of light is in absence of an external light source. Excitation of photoreceptors in retina by mechanical, electrical or magnetic stimuli can give rise to phosphenes. For example, trauma or rubbing of eye or coughing are also an example of phosphene, and these are known as pressure phosphenes. Now flashes occur when vitreous sinks, changes or pulls on the retina. With aging, there can be occasional flashes which are harmless and are due to vitreous degeneration. They are usually transient, and sudden repeated flashes of light can indicate a retinal tear or detachment. Floater. Floaters are small specks, dots or circles, lines or cobwebs in your field of vision. They can be due to aging when the vitreous liquefies and contracts, which is known as vitreous synthesis. Collagen fibers clump together and cast a shadow on the retina. Usually they are not serious and fades away and become less noticeable, and blinking does not remove floaters. They are more common in biopes, and PVD can lead to a large central floater. Now, when flashes and floaters are significant, when you notice a lot of new flashes, you have a lot of new floaters, sudden cessation of flashes, which are more serious because they can indicate that vitreous has separated without any retinal detachment, or the vitreous has separated and pulling on the retina, causing a tear, which is more serious. Floaters are retinal breaks, and sudden shower of floaters can due to retinal bleeding. Pathophysiology for sudden shower of floaters. In case of retinal break, there can be avulsion of retinal vessels, due to which RPE cells can migrate into the vitreous and thus cause sudden shower of floaters.
No, both of them can independently cause floaters.
Okay.
The bleeding into the vitreous cavity and also the release of the RP cells into the vitreous cavity both can cause floaters.
Okay.
This doesn't lead to that. Okay. It's the break formation which is important, because if you find it at the break stage, you can laser it. If you don't find it at the break stage, you will end up in a retinal detachment.
Okay. Now the question.
You understood? Yeah, please. Yeah, you understood what causes flashes and floaters? Flashes is because of the mechanical pulling on the retina. Okay, so the patient can have flashes but still not have a break. It just indicates that there is something still pulling on the retina. Okay, and when the flashes are there, it's important that you examine the periphery thoroughly, because in some areas breaks could have formed. Okay, and he was telling about cessation of flashes, because when the flashes stop, it means that either the vitreous has separated without causing a break, or it has caused a break and it has separated from the retina. Okay, so that means a break has formed. So you need to find that break and treat it. Okay, so which comes first, flashes or floaters? Flashes come first. Yeah. So first you have to have pull on the retina before a break happens. Okay, so only after the break happens, you get the floater due to the break. I'm not talking about vitreous degeneration. Vitreous degeneration can also cause floaters. That is present in a lot of people. That is constant. That is not at all important. The sudden onset of floaters, which happen due to the break, happens after the break forms only. So before the break forms, these floaters don't come. Okay, so either the vessel has to get avulsed or the RP has to migrate only after the break forms. So it's always the flashes which happen first, then the floaters come. That's how the typical pathogenesis happens actually.
Okay. Can anybody tell me the difference between retinal tear and a hole?
Giant retinal tear, hole, dialysis.
A
What are
giant
each thing?
retinal tear is a tear that is more than 2-3 clock hours, and a tear is in a hole. There is a discontinuity of the retina in that region. It can be a complete or incomplete thing, and in a tear, it's not discontinuity but just a break, like a breach in the retina. Vitreous.
Anybody wants to differ from her? All of you agree with her? Any one person not agreeing with her?
It's on only. So tear will have a flap. Hole will not have a flap.
Why is that so? You're right. Hole doesn't have a flap, whereas a tear will have a flap. What does it mean? Yes, so the pathogenesis is different. Okay, the tear is due to traction, whereas a hole happens due to atrophy of the retina. That's why it is round. Okay, whereas tear, because of direction of pull, it is usually horseshoe shaped. Okay, so that is a tear and a hole. Both are types of breaks. A break is a full thickness defect in the neurosensory retina. Okay, there are two types of breaks: holes and tears. Okay, what's a dialysis?
Separation of the retina from the ora serrata.
Okay. It's again a break, but the location is at the ora serrata. So why? How is the retinal dialysis different from other breaks?
There is no anterior lip for a.
Yeah, there's no anterior retina. So what? Anteriorly is the ora serrata. Posteriorly, you have the border of the dialysis. What is the commonest cause of dialysis? Trauma. Trauma is a very common cause. But why do you want to categorize it as a separate type of break? It's a break after all. Why is the location? Is it any different? So what is there at the ora serrata? He told straddling the ora serrata.
Attached. The vitreous base.
Vitreous base. So the gel is firmly stuck to that area. Okay, it can never separate in that area. Okay, so when you have a dialysis, the chances of liquefied vitreous entering the break and leading to a detachment is less. It still happens, but it's very slow. Okay, and because actually the gel vitreous tamponades the dialysis. Okay, so it's attached both to the anterior margin of the dialysis and the posterior margin of the dialysis. So it actually blocks the break, and the progression to detachment is slow. Okay, so a lot of times with the dialysis you get a chronic detachment, and usually they are treated with a scleral buckling rather than a vitrectomy, because you will not be able to remove the vitreous in that area. It's because of the vitreous base. You can only shave it, but you cannot remove it. So the management also changes with the dialysis. Okay. Why is again a giant retinal tear a separate type of break? You told it's 3 clock hours. So why is it again special? Why not take a break which is more than 2 clock hours and tell it as giant retinal tear? Why this 3 clock hours? Or 1 quadrant?
The chances of RD will be more in giant retinal tear than the whole. So, because like the traction is there, sir. Because it's not in the vitreous base, so the traction is more. The chances of them getting RD is more.
So because the larger amount of RP is exposed, PVR is faster, and the RD is also progresses very rapidly. More importantly, the posterior border is not attached to the vitreous. The anterior part of the giant retinal tear, vitreous is attached. So the posterior actually falls back. It rolls back. Okay, and doing surgery and attaching it's difficult. You need something like an LPFC to unroll the posterior border of the GRT. Okay, both the progression of the RD is faster and the management is also a little different. That's why we have to specially tell it as a giant retinal tear. Okay, sorry, go ahead.
Metamorphopsia is distortion in vision in which a grid of straight lines appear wavy or partially blank. Visual field can be affected partially or fully, can also affect face perception and reading ability. Pathophysiology is not completely understood, but it is due to displacement of retinal layer, mainly cones, which leads to mislocalization of light on retina. Macropsia is when the objects appear larger. It is outcome of retinal contraction. And micropsia is more common. Here objects appear smaller and it is an outcome of retinal expansion. Causes include macular disease like ARMD, diabetic retinopathy, central serous retinopathy, macular edema. Diagnosis can be by Amsler's grade, modified Amsler's grade testing, M-charts, and differential perimetry. Now, Amsler's grade is a white or black card with white or black vertical horizontal lines subdivided by 5 mm, forming a perfect square of 10 centimeters. It is presented to the patient at a distance of 28 to 30 centimeters. Each small square subtends an angle of 1 degree. So an entire grid subtends an angle of 20 degrees, superior and inferior, and 10 degrees on each side of the center. Thus the grid explores central 10 degrees of retina around the fixation point. Now macropsia will appear as distorted lines curving away from each other, and micropsia will appear as lines coming closer together.